Welcome back. I'm Mabel, Jong. You're watching WHCC TV. We're so pleased that you're here. This is continuing coverage of the World Healthcare Congress coming to you from Washington, D.C. Next up, the opioid crisis. Like the rest of the United States, Oregon is battling an opioid crisis involving misuse, abuse, overdose, and death. An average of 5 Oregonians die every week from opioid overdose. To talk more about that, we have Dr. Wui-Leong Koh. He is VP Quality Care Experience and Patient Safety, Northwest Permanente. Dr. Koh, thank you so much for your time today.
Thank you for having me.
Well, some of those numbers are pretty dire. Why are we seeing so much of this in Oregon, in that state? It has one of the highest death rates from opioids in the entire United States.
Oregon is not alone in this, and I think we're seeing the crisis peak at this point in time. Across the United States, we have over 50,000 of these deaths occurring per annually. And every day, every 24-hour period, we're looking at 130 people passing away in a 24-hour period. That's one death every 11 minutes, which is very substantial. In actuality, Oregon and Washington are high, but not as high as some of the Midwest and East Coast states. But it is starting to crest in the Pacific Northwest as well too. And this is why we're so passionate as an organization, Kaiser Permanente, in combating the opioid crisis as being part of the solution.
Well, recently there's been more clarity as to what brought us here. We have more understanding of what happened when drugs like these opioids came out and how they got into the hands of people and how people are becoming addicted. But can you, from your chair, give your assessment as to how people get hooked on these kinds of drugs?
Yes, so there's a variety of reasons why people get hooked. The medication itself is a pain medication, and it does relieve pain, but it also makes a person feel euphoric and also feel good when they take the medication. Unfortunately, our brain and the receptors that these opiates attach to, there builds a tolerance to it, and what happens is that it just takes more of this medication to get that same relief and that same feeling. And so what happens is people just generally want more of it. And so that's how people become attached to these medications, and they find it very difficult to let go of them.
And how quickly does that take hold of a person?
It depends on the biology of an individual and the genetics of an individual. But what we found is some of these attachments occur actually very, very quickly. There's been some studies shown, for example, in post-surgical patients where they've had surgeries where they prescribed just for the post-operative period for about 3 or 4 weeks. When they take the medications, if you give them enough opiate medication, there's a higher likelihood that they become attached to these medications or addicted to these medications as well too. We also see some examples in the pediatric populations as well too.
Okay, so it can be as quickly as a 3 to 4 week period where someone could suddenly feel like they can't go on without these kinds of drugs in their system?
Yeah, so when the body recovers, generally pain reduces after, for example, a post-surgical procedure or maybe from an injury. And as they recover from either an injury or a procedure, what happens is if prescribed medications and if refilled repeatedly, people will again get used to the feeling, not only for the pain relief, but also for the feeling of the mood changes that they're experiencing.
Okay. You mentioned to me earlier that you've been practicing primary care for about 23 years. And so you were at the very beginning of prescribing these opioids when you first started as a doctor. Is that right? That you wrote prescriptions really advising people to take this kind of pain medication?
Yes, I started my practice in the mid to late 1990s, and back then it was an inflection point where opiates used to be prescribed by people that were more super specialized, like the medical oncologists. Back in the late 90s, what happened was a combination of the state medical boards as well as pharmaceutical companies encouraged us, and we actually went to programs telling us that we were not treating our patients' pain well enough. And at the same time, the marketing of these opioid medications in the late 90s and early 2000s made it easier for us to prescribe these medications, and in that way it expanded the number of people prescribing the medications to the front line. And so this was one of the reasons why the prescriptions number really skyrocketed in the early 2000s. And you can see the graphs that come out from the CDC with the number of literally hundreds of millions of prescriptions of these that have been written.
Right. And so fast forward now to 2019, and you take full responsibility for being one of the physicians to have gotten these drugs off the ground. Now you want to reverse the trend. Be specific about the kinds of programs that your hospital system has in place to try to reverse this trend.
Well, we're very proud at Kaiser Permanente in Northwest. We are an integrated medical group with close to 1,500 clinicians. And about a decade ago, we started recognizing this. And the figures were staggering. And what happened about 10 years ago was we found that we were spending $1.6 million per month on opiate medications, and just on OxyContin alone, $1 million per month. And at that time, we decided we've got to do something about this. And we developed something called the Opiate Use Initiative, or OUI, and there were two main tactics that we utilized during that time. One was the development of something called the Opiate Therapy Plan. And this is where we actually make arrangements with patients and agreements on how much medications a person should take in a defined period of time. We didn't do that before, so it was a free-flowing proposition. And when we did that, we also made sure that we monitored them. So we did urine drug screens to ensure that they were taking the medications, and so that they weren't diverting them. And we also made sure that we actually did what we call pain inventories, so that we said, if we're giving medications, we want to make sure that it's improving their pain. That, together with a pharmacy initiative where we actually took pharmacists and actually put them side by side with practicing clinicians like myself, identifying patients essentially that were too high in what we call MME, or morphine milligram equivalents, and essentially helping us taper patients down that were high use. I utilized myself as a primary care doctor, these pharmacists multiple times. Just to give you some quick statistics, at Kaiser Permanente in Northwest, 10 years ago, we were at an average of 97 MME. Only 11% of patients had urine drug screens and the brief pain inventory. A decade later, we're down to 39 MME, which is a substantial change, and over 80% of our patients have urine drug screens and the brief pain inventory that we do. Okay. All these tactics that we're doing is we're definitely headed in the right direction, but we still have a lot to go. So there's a couple of examples.
Yes, absolutely. Pretty dramatic results there. Is there any data to show that you can wean people who are hooked on this with other types of medication, pain medication, without the addictive properties?
So yes. We have bolstered our addiction medicine resources here. In addition to our mental health and wellness resources here, there are other medications on the market, such as Suboxone, which some people may have heard of, and it takes special dispensation to write for those, and there are several people in our organization that can actually write for these medications to help. But it's mostly it goes beyond medical treatment. It's about making sure that the community surrounds the patients as well too. Not all people that are addicted to opiates are homeless. I want to make that clear. There are literally soccer moms and dads and things of that nature. I've had patients before where I've seen them lose everything that were average looking people that drive SUVs and take their kids to school, that have lost everything because of these opiates. So we have to make sure that we surround the individuals, not just medically, but by community as well too. And we're working with our community resources around the Oregon and Southwest Washington area to help.
Thank you, Dr. Koh, for sharing your work, and best of luck to you and your team for doing the work that you do. Thank you.
Thank you.
And I'm Mabel Jong. Stay tuned. We have other interviews to come. They're planned for you. Thank you.